I'm here with Jessica Ciralsky. Jessica, I'm happy that you're here. You just give this wonderful talk on fungal keratitis. Let me get you to sort of give me the lay of the land here, and then I'll have more specific questions for you.
Absolutely. So I was doing an interactive case presentation, and I presented a case of a 13-year-old girl with a really difficult fungal ulcer. It was not diagnosed for 4 weeks, and so we talked about difficulties in diagnosis, difficulties in treatment, especially when it's advanced.
So yeah, so tell me. I'm not going to ask you to present the whole case. Secretly, I am. So no, just give me a little bit of clinical context for it.
Absolutely. So I saw her once we had a diagnosis, and I had the benefit of knowing what she had. But so the story previous to coming to me was that she is a contact lens wearer. She had worn it in pools and hot tubs and presented to an ophthalmologist who diagnosed her first as a corneal abrasion, wasn't getting better on a topical broad-spectrum antibiotic, went on to do fortifieds, still wasn't getting better. They cultured, diagnosed as herpes, still wasn't getting better, diagnosed as acanthamoeba on antiparasitics, still not getting better, and then finally went for a second culture, corneal biopsy, and then was diagnosed with fungus.
So that's interesting. I mean, the interesting part of the study of this presentation, which I guess is not really relevant, is why it is that they jumped right to a acanthamoeba when fungal keratitis. I mean, it's not the most common keratitis, but in my community, which is your community, it's a lot less. Fungal keratitis is a lot more common than protozoal keratitis.
Yeah, especially in Florida, right? She was on a trip to Florida. She was in a New Yorker, but on a trip to Florida. She was a contact lens wearer, and I think the water, being exposed to water, fresh water, and pools and hot tubs, maybe made somebody think about parasitic. I was not involved at that point in the care.
Oh no, I wasn't suggesting for a second that you were. So let me ask this: with bacterial keratitis, there are pretty consistent ways that we treat it, even if we have to vary treatment based upon the response in the clinical context that the patient has. With fungal keratitis, there aren't such rigid treatment protocols, and that's always a sign that treatment is sort of suboptimal, or there would only be one way to do it.
Yeah.
So talk about the treatment of fungal keratitis generally. I want to hear how you manage this patient. But in general, what is the right way to approach this?
Yeah, I think it depends if it's filaments or filamentous or if it's yeast. And in our case, it was fusarium, so filamentous. And I think based on the MUT trial, natamycin is probably first line. It's easy to get. And so patient came to us on natamycin, which was nice. We added in a second topical medication. I added in amphotericin and oral voriconazole. And so I think for the more difficult cases, this was pretty advanced. I would add in an IV azole medication or an oral azole medication. I sometimes go to a second agent when it's an advanced case, but I would start with one agent, natamycin if it's filamentous, and maybe ampho if it's yeast.
Were there any clinical clues, or more generally, can there be more clinical clues with these patients just at the slit lamp that can, I mean, certainly not be diagnostic of fungus, but alert you that should be in your differential?
Sure. The feathery classic teaching of these ulcers, also satellite lesions, can maybe make you think about fungus. This was sort of just a white limbus to limbus ulcer. So hard to tell, but not getting better on treatment should make you think about atypicals and fungus and acanthamoeba.
And a lot of the times, even when the region of the keratitis is limited, it's a lot more posterior than you would normally think of seeing with bacterial. What was the duration of your treatment, and how did you know when to stop therapy?
That's a great question. It was limited, and at the beginning only because she perforated. So she had a near perforation prior to presenting to us, and then I treated her 7 days inpatient, 3 days outpatient, and there was a small perforation, and that made me take her to the OR. So that was pre-operating room, but then I did continue. I continued orals for about 4 weeks, and she had some elevated LFTs, so I stopped that after 4 weeks. But I continued topicals an extra 12 weeks and tapered them over those 12 weeks.
Wow, I mean, this is clearly even for a fungal case, this is not a typical case. But of course, that's why you presented it.
Yeah.
You're not going to do something trivial here. So, what are the take homes for me as a clinician with a comprehensive practice?
Yeah, absolutely. I think look for it is probably the biggest one. And if an ulcer is not getting better and you don't feel comfortable treating it, send it out. I think the other big take-home point that I always like to emphasize is reculture. I always say a negative culture from someone else it's not a negative culture until I've cultured it myself. I don't just take the word for it that it's negative if someone else has done it. There's different ways of culturing, but I think that you really need to get tissue. You really need, I take a 15-degree blade, I really plate it out, put it on slides, and look at it. And confocal is another really great tool. This was a case from 8 years ago, so confocal wasn't quite as mainstream as it is today, but I think it's another adjunctive tool.
Yeah, these are great points, and although as everyone, and particularly Jonathan Kahn says, anything can be simplex, that in a context like this really has to be a diagnosis of exclusion, and fungal keratitis is one of the things that needs to be excluded. Well, great. This is wonderful stuff. I want to thank you for bringing this tragic case to us, but at least I got something out of it. And you're a very busy person, particularly at this meeting. I want to thank you for the generosity of the time you've shown us today.
Thanks for having me.